Hi, everyone, and welcome to this anesthesiology review video. My name is Jake Reck. I am a fourth-year medical student at Western University in Southern California. I decided to make this video because I noticed there wasn't a ton of review material out there geared towards third and fourth-year medical students on their anesthesia rotations. This was heavily inspired by Dr. High Yield and the Divine Intervention podcast, as well as a preceptor of mine's notes. It pulls a lot from the Stanford Guide, which I highly encourage you to download. This is intended to be a broad overview of OR anesthesia, which can help give you a primer or get you started to excel in your rotations. That being said, let's get started. All right, so what is anesthesiology? There are three main components. There's analgesia, think loss of pain perception, think amnesia, loss of memory, and anesthesia, which is the loss of proprioception, temperature, vibration, feeling. And here I have a triangle for the triangle of anesthesia, where you need a balance of all three of these things to really be good at your job. You don't want your patient to be feeling pain. You don't want them to remember what happened in the operating room. And you certainly don't want them to feel anything poking around during surgery. There are three phases of anesthesia: induction, maintenance, and emergence. Think of anesthesia like flying a plane. It's really tough to take off. It's really tough to land. Lots of times you can cruise in the middle, but you can still get some turbulence from time to time. For induction agents, you have your IV anesthetics like propofol. You could also just use gases for that. You could use each of these for maintenance as well. And for emergence, you just want to turn these off because you want to get them off the medications. There are 4 stages of anesthesia. Now, this gets a little complicated, but this refers to the depth of anesthesia. You can use their eyes as a guide, but also normally these are taped shut. Just think of stage 1 as being awake, stage 4 as being extremely deep, stage 3 as being generally where you have them for anesthesia. But the most important thing is stage 2, in between awake and anesthetized, where this is dangerous. If you extubate during stage 2, you're going to have some risk of laryngospasm, which can be a medical emergency. Now, you're going to see a patient, you're doing pre-op. What are some things you should be thinking about? Well, look at their baseline vitals. If they're a woman, make sure they're not pregnant. Also, check the hemoglobin. If there's a lot of risk of bleeding during surgery, you want to make sure the hemoglobin isn't too low. Look at what medications they're on and when they last took them, as long as they're relevant. If there's any medication allergies, their past medical history, like prior surgeries, their electrolyte balance, particularly potassium, especially for end-stage renal disease patients. When's the last time they ate? You don't want to be doing an elective surgery if they ate a cheesesteak an hour ago. A really important question, too, is have they had anesthesia before, and did anything go wrong? That way you can be a little bit extra prepared if they encounter something in the past. 2 other things to think about are your Mallampati classification, which you will most likely be asked about. You want your patient sitting up. You want them to stick out their tongue and open their mouth without saying ah, and see how much you can visualize. So 1, you can see everything. You can see that uvula, soft palate, hard palate really well. And as you go up to 4, you see less and less. You also want to think about their ASA. So a healthy patient is going to be ASA 1. Somebody with well-controlled hypertension, diabetes is 2. 3 is okay. Now, maybe they have some end-stage renal disease, some very poorly controlled diabetes. 4 is very serious. Like think your cabbage. 5 is somebody who experienced trauma, is not expected to survive without this surgery. And there's actually a 6, which you would see for a transplant. So let's talk about vitals and monitors. So we have our oxygenation, circulation, ventilation, and temperature, as well as many others to consider. Oxygenation. So we have P big AO2, which is alveolar oxygen, lungs. P little AO2, which is arterial oxygen. So P AO2 is affected by the percent of inspired oxygen, which is 21% in room air. But if you're giving somebody 100% oxygen, then you're going to expect PaO2 to be about 5 times higher. The normal value is 80 to 100 for P little AO2, and we can increase the amount of oxygenation with FiO2, tidal volume, and positive N expiratory pressure. If you want to do some quick math, a 10% FiO2 increase should give you about a 60 PaO2 increase. So if you're giving somebody 100% oxygen and you see a ABG give you a PaO2 of 100, that's not normal. You would expect it to be considerably higher. Circulation, we're talking pulse oximetry. So this measures the percent of oxygenated hemoglobin in the blood. It does this by emitting light at different wavelengths and measuring the absorption. But it's super important to remember this is on a 30-second delay. So if your patient is desaturating quickly, you are going to be even farther behind than you think. This is a very important monitor. It should be the first thing on when somebody goes into the OR, and it should be the last thing off when you're getting ready to transport them to the PACU. So remember your hemoglobin saturation curve. It's dependent on the partial pressure of oxygen. And you see they kind of fall off the cliff at about PaO2 of 80. That's why that's the minimum in the range. Also remember you can right and left shift the curve. Some notable things are temperature, heat, right shifts, also acid-base disturbances, an acidic environment, right shifts your curve. Other important things to note, so if you disconnect it, it should read 85%. Methemoglobinemia confuses it and causes it to read 85%. If you have carboxyhemoglobin, it's going to read really high. Even though your actual oxygen content is really low, it reads carbon monoxide the same. So it's going to artificially reassure you. Cyanide doesn't affect this, so that should read normal, but they're not going to be able to use their oxygen. Some things that can affect the reading too. Blue nail polish is the one that affects it the most out of all the nail polishes. Movement and motion is huge. You might see some desaturation when your patient is moving around. Don't freak out. This is just movement of the probe. Also, if you happen to accidentally put the blood pressure cuff on the same arm as the pulse oximeter, you're going to see desaturation every time the blood pressure cuff is going off. Also note that your heart rate for the EKG and pulse oximeter should match. If they don't, then something is wrong with your equipment. EKG. So this can tell you the rate, rhythm, and presence of ischemia. You will most often see a 3 or 5 lead system. 3-lead system was really good at showing you rhythm using lead 2. The 5-lead system has lead 5, and the combination of all this is really good at showing you ischemia. You're going to have to learn how to put these on your patient. The mnemonic is white on right, on the right shoulder, smoke over fire, the black over the red, and clouds over grass, the white over the green. And you have V5, which should go where V5 goes, usually between the black and red line. Note that you're going to have to change the positioning depending on the surgery. For example, if you're flipping your patient or if they're operating where you would normally put the probes. For blood pressure, you have the non-invasive blood pressure cuff. Based off of how it works, the map is more accurate than systolic and diastolic pressure. You also have invasive measures like the A-line. So this is really useful because it gives you real-time measurements. Your blood pressure cuff might be cycling every 3 minutes. So in between, you have no idea what's going on. However, the A-line is not necessarily more accurate than the blood pressure cuff. For example, if there's some arterial stenosis near where you put the A-line. Remember that MAP is 2/3 diastolic pressure plus 1/3 systolic pressure. And if you want a little mental math shortcut, you can do systolic minus diastolic over 3 plus diastolic. Very useful if, say, you have a pressure of 73 over 43. So you have 73 minus 43 is 30, over 3 is 10, plus 43 is 53 for your MAP. Standard blood pressure of 120 over 80 has a MAP of 93. And also remember from your first year of med school, blood pressure is cardiac output times systemic vascular resistance. Cardiac output is heart rate times stroke volume. And cardiac index is standardized cardiac output. So cardiac output over body surface area. And you expect this to be 2.6 to 4.2 in most patients. So this is the big money slide. If you're going to take away anything, it should be the information here. So you're going to be in the OR, your patient's blood pressure is going to be dropping, and you're going to be asking your preceptor, how low is okay? So this is a debated topic, and different numbers are thrown out. I think a really big map to think about is a map of 50. You do not want to go below a map of 50 because in a normal, healthy patient, you're going to stop perfusing the brain below this pressure. So the brain is amazing and can auto-regulate its blood flow based off of a wide range of blood pressure. So from a map of 50 to 150, the brain is okay, but when you dip below 50, it starts to not be perfused. If a patient is chronically hypertensive, this is shifted to the right, as you can see in this figure, and you can't get away with a pressure of 55 anymore. It might be 60, 70, or even higher, depending on what they're living at. I think a good rule of thumb is plus or minus 20% for their baseline blood pressure. I also wanted to throw in a note here about Cushing's triad. I never realized why it was increased ICP, bradycardia, and hypertension, but this really explains it. So cerebral perfusion pressure is your MAP minus your intracranial pressure. So if your intracranial pressure is rising, what's going to happen? Your blood pressure has to rise in order to maintain your cerebral perfusion pressure. And as a result, you're going to have some reflex bradycardia. So remember that blood pressure varies by position. Think of us as just tubes of liquid affected by gravity. So the higher up you go from the heart, you're going to have less perfusion, and the lower vertically you go, the more pressure you're going to have. Good way to remember this is pH equals 7.410. So a height change of 10 centimeters gives you a expected pressure change of 7 millimeters of mercury. So if you look at this figure, you have probe 1 at the heart, probe 2 20 centimeters above that at the head. If you have a patient in this position, you can expect there to be a pressure drop of about 15 based off of your reading if you're reading it at the heart and their head is 20 centimeters higher. If you have a patient in this position, you absolutely need to keep this in mind. Also, if you're putting them in any sort of Trendelenburg position. All right, capnography. It's a good measure of ventilation. So this is our exhaled CO2. Note that the end tidal CO2 being shown is about 5 less than your PA CO2. So 40 is too high, since we would expect 40 to be about the normal value of your PA CO2. Think of it as your metabolism. As your metabolism goes up, like malignant hyperthermia, your end tidal CO2 is going to be really high. If it goes down, if you're not being perfused really well, it's going to drop. Also, the way you're going to use this the most is to confirm your tube placement when you intubate somebody. Note that a low respiratory rate and a low tidal volume mean high CO2. And super important physiologic concept is high CO2 causes brain vasodilation and increases perfusion, and it causes lung vasoconstriction. Temperature, you're not going to monitor as frequently as the other vitals, although we probably should. I like to think of low temperature, meaning enzymes do not work properly. So you're going to have a lot of potential issues, from arrhythmias affecting your drug metabolism. Bleeding is a big one. Lactic acidosis, higher risk of infection. You expect blood pressure to go up with low temperature, as well as a higher heart rate and a left shift of your hemoglobin curve. There are a lot of ways to measure core temperature. Skin, axillary, rectal are all pretty inaccurate, even though you might use them for convenience. A great way to do this is with an esophageal probe that you can put in during the surgery. If you happen to have a central line in, pulmonary artery temperature is the absolute best for core temperature. Something you'll see a lot too is a bear hugger be used, and it's really effective because it circulates air. So by convection, you're going to be distributing heat to the patient much better. And this is important. Remember, operating rooms are cold, and lots of times they have a thin gown or nothing on, so they definitely need the extra help. Something else you might see is a BIS monitor, so a bispectral index. This measures brain activity to assess consciousness. So this can help tell you with reasonable accuracy how awake your patient is if you are concerned. This does have about a 2-minute delay, though. So if you see values of about close to 100, they're awake. 70 to 90, they're under a little bit, like maybe you gave them a little bit of propofol like you would for a colonoscopy. 30 to 60 is what you would expect to see with general anesthesia. Lower than 30, they're a little bit too deep, and you need to lighten that up a little bit. All right, fluid management. So we have our crystalloids. That's normal saline, which is normally 0.9%, and lactated ringer. Those are most likely the only two you'll see. So normal saline has an osmolarity of 308, which is half sodium, half chloride. And this can cause a hyperchloremic metabolic acidosis if used in excess, as well as acute kidney injury. Lactated ringer has an osmolarity of 273, so a little lower, and it has a lot of stuff in there. So we have sodium chloride, also notably potassium, calcium, and lactate. This can be useful in patients with electrolyte imbalances. Note that the lactate does not cause lactic acidosis issues, and the potassium is okay in patients who are hyperkalemic. Just 4 milliequivalents of potassium is not going to cause them any issues. And if you're resuscitating somebody with crystalloids, you want to use them in a 3-to-1 ratio, because remember that the ICF is 2/3 and the ECF is 1/3, and it's going to get redistributed. So if you actually want to get that in circulation, you need to give 3 times as much. The collaid you're going to see is most likely albumin, and you can give this in just a 1-to-1 ratio. It's usually more expensive. You need less. The main contraindication I'm aware of is in traumatic brain injury patients. So your general strategy should be tailor this to the patient, the surgery, in this scenario. There are guidelines out there, and I'll talk about them, but just really see what's going on. You don't want to give them too many fluids, but you want to give them enough. I mean, think about how much blood loss they're having. Think about when the last time they had anything to eat or drink. Have they been NPO for 48 hours? You have to be thinking about all of this, and you need to prepare. If you expect a lot of blood loss too, make sure you type in cross ahead of time. You don't want to be doing this during surgery. You don't want to have to wait for anything. A general guide for classical management, you probably heard of the 4-2-1 rule. So for the first 10 kilograms, 4 cc's, second 10 kilograms, 2 cc's, and then every other kilogram, 1 cc. This can be just shortened to 40 plus weight cc's per hour. So they have an existing deficit. You need to use this maintenance times how long they've been NPO for, and then try to add that to expected losses of blood, urine, evaporation. And you want to try to stay as equal as possible. You don't want to just flood every single patient with fluids without thinking. Now let's talk about our inhalation agents, our gases. So some definitions. Uptake is the gas being taken up by pulmonary circulation. And if there is low blood solubility in the gas, you have low uptake and fast induction. If you have a high cardiac output and a right to left shunt, then these slow induction for these inhalation agents. Super important thing to remember. Induction rate is proportional to lower blood solubility. I think of this as the blood doesn't want it. It doesn't want to waste time gathering all this up, so it's able to jump to the brain and have its effect more easily. Potency is different than this. So potency is related to lipid solubility. That's how strong it is. So the mechanism of action of these gases, it's not clear. It affects a lot of receptors, but we don't completely know. Also, remember that these can trigger malignant hyperthermia, and all of them increase cerebral blood flow and intracranial pressure. They decrease MAP, they preserve minute ventilation, and they decrease GFR. All right, let's talk about MAC. This is a very important concept I'm sure you'll come across. This is minimum alveolar concentration. It is inversely proportional to potency. So 1 MAC means that 50% of patients do not respond to surgical stimulus. 1.2 MAC means that 95% of patients do not respond to surgical stimulus, and we do not want our patients to respond to surgical stimulus. Different gases have different MACs, as you can see in this table. Like SIBO has a MAC of 1.6%, and MAC is great because these are additive across agents, so you can have a really good understanding of where you're at with your depth of anesthesia by thinking about MAC. These are also potentiated by your benzodiazepines, narcotics, and IV agents like propofol that you're most likely going to give one or all to your patients. So you don't need to always run at a MAC of 1.3 to make sure they're under. Also note the age of the patient is really important. A very young patient is going to require more gas to keep them under, but as a patient gets older, you need less. The MAC decreases by about 6% every decade over 40. So if you have a 80-year-old patient, it's decreased by 24%. So you need about 76% of the normal MAC for them. Looking at the specific inhalation agents from least to greatest solubility, we have desflurane and nitrous oxide about tied, sevoflurane in the middle, then iso, then halothane. For MAC, from least to greatest, we have halothane, then isoflurane, sevo in the middle again, then our desflurane and nitrous oxide. So that means that desflurane and nitrous oxide are the fastest, and halothane is the most potent. So nitrous oxide is used as an adjuvant, so it increases MAC and anesthetic delivery through the second gas effect. So you would never use nitrous oxide alone. If you remember from the previous slide, its MAC was over 100%, so you're never actually going to be able to use enough of it. But it's often combined with other inhalation agents like SIBO because it gets absorbed very quickly and then increases the partial pressure of that SIBO. And so you're giving more SIBO basically without having to use more SIBO. Note that it can create bubbles in air-filled cavities, so you want to be really careful about using this in ENT surgeries or GI surgeries like bowel obstruction. Isoflurane, it's pretty pungent and cheap. I've never seen it used. Sevoflurane, I've seen used the most. It's sweet smelling. Desflurane, it is very fast, which is very convenient to use. However, it is pungent. Also, it's actually the only anesthetic that's affected by elevation. All of them work by partial pressure in their vaporizers, except for desflurane. So be aware of that if you decide to do anesthesia in Colorado. IV anesthetics are used for induction because they work really fast. They're also used for monitored anesthesia care, which is unfortunately a different MAC, and they're used for TIVA, which is total intravenous anesthesia. So you can use these for anesthesia all throughout, not just induction. Most of them work by GABA-A activation, affecting the chloride channel duration or frequency. So this is our propofol, barbiturates, etomidate, and benzodiazepines. There's also one different one, ketamine, which is an NMDA antagonist. Propofol, you are absolutely going to see it. It's a wonderful medication, very common. You can't miss it because it is milky white. So it is in a egg yolk emulsion. So it is not allergenic. Most people with egg allergies are allergic to egg whites. Once you use a vial, you should throw it away because of bacterial growth that occurs very easily. It is painful on injection, and you'll see some people use lidocaine first or mix the propofol with lidocaine to try to lessen this pain. Most important thing about propofol, it gives you a profound decrease in your systemic vascular resistance. When you give propofol, you need to be prepared for someone's blood pressure to drop. It also causes respiratory depression. If you are going to use Tiva, you do this at an infusion of 100 to 200 mics per kg per minute, but you're going to have to frequently adjust this depending on your patient. Propofol very quickly redistributes into fat, but if you're using it for a really long time, like in Tiva, this can be saturated and it's going to last longer than you think it's going to last. So if you are using it for 4 hours, maybe cut it off an hour before. Also, there is absolutely no pain control with propofol, and it has anticonvulsant and antiemetic properties, which is often why you would choose to do Tiva. Etomidate also gives you pain with injection and no pain control. It's great because it maintains hemodynamic stability. You're not going to have the blood pressure drop. So if you have some sort of emergency case, you may want to consider it, but it causes adrenocortical suppression, so that could give you some different problems. Barbiturates, I don't think they're used in the US anymore. You might potentially see this for electroconvulsive therapy. Benzodiazepines, you're going to see midazolam or Versed. So this is mostly used as an amnestic agent. So for the patient to forget what's going on, being wheeled into the operating room, having all these monitors attached to you, this is all traumatizing and a little dehumanizing. You don't want to remember that. So this is great for that. Make sure they sign their consents, though, before you give them Versed. And it does not give any analgesia like the others. If you give too much, you can reverse this with flumazenil. However, flumazenil is much shorter acting and has a shorter half-life. So they still need to be monitored because you can give flumazenil, they could be fine, and the flumazenil can go away, the benzo can still be there, and they can revert back to their previous state. Ketamine is a really interesting one. It's a complete anesthetic, so it can give pain control, your anesthesia, and your amnesia. It is known for causing a dissociative state. If you see somebody on ketamine, you'll understand what I mean. You can give them hallucinations and nightmares, less so in children, and less so if you use it with other IV anesthetics like propofol. It also causes sympathetic stimulation through catecholamine release, so you're going to expect to see blood pressure and heart rate go up. Ketamine is becoming increasingly more common. I'm sure you've heard of ketamine clinics, so keep your eye out for this one. Below, I have some common doses for the different medications we were talking about. The one you should really know is propofol. Just think 2 mg per kg of propofol. I've seen folks just give 200 of propofol to pretty much every single patient, but that varies. Opiates. So this is for our analgesia part of the triangle, and we're most interested in the mu-opioid receptor agonism. Should be well aware of the effects of opiates. Remember, there's significant respiratory depression, and they are hemodynamically stable alone, but if you combine this with other anesthetic agents, that's not the case. So there are a lot of different options. For approximate equivalency, you have morphine kind of as your standard. Alfentanil and meperidine or Demerol are 10 times weaker. You have dilaudid or hydromorphone, which is 10 times stronger, and your fentanyl and remifentanil, which are about 100 times stronger than morphine, and sufentanil, which is 1,000 times stronger than morphine. So fentanyl is probably going to be the one you see the most in the OR because it works very quickly and lasts a short amount of time. However, you cannot use massive amounts of it as an infusion because it has a context-sensitive half-life. The more you use, the less it's going to go away. So it's really good for quick boluses of pain control. Dilaudid, you'll probably see for post-op pain. Remifentanil doesn't have the problem of fentanyl and can be used for infusions. Alfentanil just works exceptionally quickly. Morphine, you probably won't see. Demerol, if you're going to see it, it's probably for post-op shivering. We don't know why this works, but it works really well. Also for morphine and Demerol or meperidine, their metabolite is renally excreted, so be careful in the end-stage renal disease patients. just keep in mind for pain control, you can use things besides opiates. You want to try to limit your opiate use as much as possible, even though they work really well for pain control. So consider Tylenol or Toradol, which is ketorolac. Intraoperative hypertension. So there are a ton of things that can cause this. The ones you should immediately think about are, is your blood pressure cuff being used correctly? Is it the right size? How does it relate to where the patient's heart actually is? Is there light anesthesia? Are they experiencing lots of pain? If they're having pain and they're not that far under, then your blood pressure and heart rate are going to shoot up together. If you see hypertension, some ways you can treat it are, well, one, deepen the anesthesia and give pain medication if they need it. You can consider your calcium channel blockers, hydralazine, and nitroprusside, all of which cause arterial dilation. For hydralazine, note that it works a little more slowly. And nitroprusside has a nasty side effect of potential cyanide toxicity. There is also nitroglycerin, which causes venous dilation, and your beta blockers, labetalol, which is an alpha beta blocker, and esmolol, which is more of just a standard beta blocker. Hypotension is most commonly caused by unfortunately, by the anesthesia that you're giving. If you've been paying attention, you've noted that your gases, your propofol, etc., pretty much all cause hypotension. So consider this first. Also, just a lack of stimulation. A surgeon making cuts is going to increase their heart rate and blood pressure. If you're waiting for a surgeon that's an hour late, then their vitals are going to start dropping. We also have numerous other causes like hypovolemia, shock, think bleeding. That should be at the top of your list always. Also anaphylaxis, measurement error, etc. So to treat this, most importantly, treat the underlying cause. For example, if they're bleeding, if it's being caused by your anesthetics, maybe you can turn them down a little bit. Give them volume if you need to. Also, if you're giving lots of PEEP, this decreases venous return, so you can dial down your PEEP a little bit. And then you can give vasoconstrictors and inotropes as necessary. So here are drugs you're going to see a lot. I'll just zip through this. Phenylephrine, this is alpha-1, so it's just going to vasoconstrict. Norepinephrine or Levophed, you're going to use that slightly less often because it's very, very powerful and can cause too much peripheral vasoconstriction. Epinephrine is going to cause alpha and beta stimulation. Ephedrine actually stimulates your endogenous catecholamines, so it's going to cause alpha-beta stimulation. So basically, if you see isolated low blood pressure, phenylephrine is great. If you see low blood pressure and low heart rate, ephedrine is great. You can also give vasopressin, which can vasoconstrict with the V1 receptor. The V2 receptor is the one that has to do with the kidneys. You can also consider dopamine. Just note that it is very dose specific. Low dose, it more so functions to increase renal blood flow. Medium dose, it's more beta 1. Higher dose, it's more alpha 1. You can also think about milrinone, which is a phosphodiesterase 3 inhibitor. So that means it causes vasodilation and inotropy. You will most likely see this in an acute heart failure patient. Also, dobutamine, the inotrope, which functions mostly on beta 1 and beta 2 receptors. So neuromuscular blocking agents. So these are our paralytics. You have your depolarizing agent, which is succinylcholine. So this is just it's an agonist. So it causes prolonged muscle depolarization. It locks them down. It's mostly used for ease of intubation because it is very fast acting with a short duration. Consider that your patient might have a pseudocholinesterase deficiency. So if you just use succinylcholine and they're paralyzed much longer than you thought they would be, then this is probably the reason. Also, it increases potassium due to that muscle action. So you want to be really careful in a patient with hyperkalemia. It can trigger malignant hyperthermia as well, which is a ryanodine receptor defect in the muscle. If you are unfortunate enough to see a patient with malignant hyperthermia, call for help, but you want to quickly stop the offending agent and treat with dantrolene as appropriate. Then we have our non-depolarizing agents, so our rocuronium, vecuronium, cisatracurium. So I've most commonly seen rocuronium because it's kind of intermediate acting, and you're going to use this more in surgeries that require muscle relaxation. So for example, some sort of abdominal surgery like a laparoscopic cholecystectomy, they don't want the abdomen to kind of be pulling against them. They want it to be relaxed. So you can really help your surgeon out by using these agents. And they function as a acetylcholine receptor antagonist. They take a little longer than succinylcholine to work, usually about 2 minutes to onset. And your patient's not going to recover starting for at least 30, 40 minutes. Um, Special note for cystatricurium, you're not going to see it as often, but it's useful because it's cleared through Hoffman elimination, which means there isn't an organ like the liver or kidney that degrades this. One way you can monitor how paralyzed your patient is with train of four. So you may be an institution that uses probes, which can deliver a train of four shock. If you see one twitch in your patient, that usually means they're reversible. And note that the diaphragm is the absolute last thing to be blocked. And you can use the corrugator supercilii, so the muscle above the eye, to check the depth of the blockade. So you're going to be putting your probe right about here. All right, reversal agents. So why do we need reversal agents? Well, the non-depolarizing blockers last a really long time. We don't need reversal agents for succinylcholine because it only lasts about 10 minutes. We just use it to loosen up the patient to help us intubate, and then it goes away. So we reverse with neostigmine, which is a acetylcholinesterase inhibitor. You use 40 to 50 mics per kilogram, but it has a ceiling effect. If they're not reversing, you can't just keep pumping them full of neostigmine. It's not going to work. When you give neostigmine, you're also going to give glycopyrrolate. That's because neostigmine is going to cause bradycardia and muscarinic side effects. It's an acetylcholinesterase inhibitor. Glycopyrrolate is normally 1/5 of the neostigmine dose. It is really important to not reverse your patient until they are ready. You have to wait for recovery to start a little bit. So that's that one twitch that I was talking about before. If the patient isn't ready, you can actually prolong recovery. So what if your patient isn't ready, or what if you accidentally prolong recovery? What do you do? Well, if you used rocuronium, vecuronium, then you can use Zigamidex to reverse. This is a newer medication, and it was designed to directly bind rocuronium. So it works very well and very quickly. It is superior to neoglyco in pretty much every single way, except it's more expensive. So your institution may not use it, or they may not use it unless absolutely necessary. One thing to note is that it also binds hormonal contraceptives. So if your patient's taking them, you have to let them know that they're not going to work for about a week. Post-op nausea, vomiting. So why do we care? Well, this occurs in about a third of patients, and they certainly don't want to wake up feeling nauseous and vomiting. Your nurses and your patient are going to be very unhappy with you. There's also aspiration risk, and it's going to prolong their stay, which is associated with other risks. Things to look out for, female patients, if they have a history of motion sickness or post-op nausea and vomiting, if they're non-smokers and they're younger, that all increases the risk for post-op nausea vomiting. So you may want to take extra care in those patients. Your gas, your nitrous oxide, your neostigmine, and your opiates all make this worse. Propofol actually helps. So one of the main reasons you might want to consider using Tiva, just a propofol drip, is a patient that has a history or high risk of post-op nausea and vomiting. So during the case, you can do some things to help your patient out as well. So Zofran or ondansetron is very commonly used. So guidelines say to give this about 30 minutes before emergence, but in a shorter surgery, I see a lot of people just give it right away. It's better to give it right away than to forget about giving it 30 minutes before emergence or to give it last second. So remember that no drug is negligible. So Zofran may be handed out all the time, but it has a risk of things like a QT prolongation. So think about what you're doing. You also will likely see Decadron or dexamethasone. So this is given again after induction. Your patient may have a scopolamine patch, and this again might have some of those muscarinic side effects. Phenergen or promethazine and prochlorperazine you'll often see post-op. And Reglan is also given as well, very commonly. This is metoclopramide. It is pretty useful in patients with gastroparesis, so like a diabetic patient, think about this. Definitely don't use it in Parkinson patients since it has anti-dopaminergic action. A lot of studies have shown that Reglan does not work very well. It's still being used a lot, but Zofran and Decadron, especially used in combination, add together to help reduce this risk. So if you want to be really careful, Zofran, Decadron, maybe Reglan plus Tiva is a really good idea for your patient. Local anesthetics. So these block voltage-gated sodium channels and prevent action potentials. You may remember from first year of med school that if their pKa is closer to 7.4, it's going to be more non-ionized and it can cross membranes and work a little bit more quickly. So these are used all the time in regional anesthesia, pain management blocks, and epidurals, which we'll talk a little bit about later. Remember that these, again, are non-negligible. These have maximum doses and can have some serious side effects. You're often going to see these used with epinephrine because this vasoconstricts vessels and helps to localize the medication where you want it to be. Some side effects you might see, or if your patient's awake, they might tell you they have a metallic taste or some tinnitus. You'll see this a lot in patients getting epidurals where it's accidentally injected into the bloodstream. And there is a big cardiac toxicity risk because it affects the conduction system. Let's talk a little bit about the ventilator. There are a lot of different ventilator settings, and it depends on how new your ventilator is. The most basic one is your volume control. You say, give the patient this tidal volume, and then you have some pressure accordingly. You also may have a pressure control setting where it's the exact opposite. You give them a specific peak pressure, and it's going to adjust the tidal volume accordingly. Normal peak pressure is going to be about 16 to 20, and you really want to think about this if your patient is at risk for barotrauma. Also note that in GI cases where the surgeon is pumping gas into the patient's stomach to help visualize things, that's going to be pushing against the diaphragm, and that's going to increase your peak pressure. You can also counteract this a little bit with PEEP if you choose to do so. A couple other settings I want to mention really quick are assist control and SIMV. So the main difference between these two, it gets very complicated, but they both let your patient take breaths on their own. Assist control is going to give the full tidal volume that you set for the patient when they go to take a breath. SIMV is going to let the patient just take their normal breath, however high or low that tidal volume may be. It's nice to use some of these settings or some of the other more complicated ones as your patient is emerging and as you want to let them breathe on their own a little bit, because breathing against a ventilator is very difficult. So for ventilator parameters, so you hooked everything up, what do you set? There's a lot of variation to this. I would highly recommend just looking at what your preceptor does and do that. You're probably going to hear me say that a lot more coming up. Tidal volume, you could generally think about 6 to 8 mils per kg. I've seen some people go up to 10. Respiratory rate, you're going to normally think maybe 8 to 12. For PEEP, a lot of people don't set this at all. 5 is pretty negligible, or it could be beneficial to increase this in certain cases. FiO2, you don't want to just blindly set to 100% in every patient. 100% oxygen can be harmful. It's been shown to have some detrimental effects in patients, especially over a long period of time. You've probably heard about oxygen-free radicals. So you actually want to set the FiO2 as low as your patient can handle. This depends a lot on how sick your patient is. The IE ratio is inspiration to expiration. This is normally set at 1 to 2, so they're going to spend twice as long in expiration. This setting is normally fine. You may see it increase to 1 to 3 or more in certain patients with obstructive lung disease. You're going to be setting your air and nitrous as your secondary gas. So some folks are going to like to use the nitrous oxide, some don't. So you're going to have oxygen and air, or oxygen and nitrous oxide if you're not getting 100% oxygen. You're also going to want to dial in your gas. So like if you're using sevoflurane, set it to whatever percent you want to deliver your desired MAC. There is also a APL valve, which controls your bag ventilation. So you don't worry about this at all if your patient is intubated. This is only if you're bagging. All right, if you're interested in anesthesia and you're about to start your first rotation, you're probably very excited to learn how to intubate. So let's talk a little bit about the equipment and what you're going to expect. So you're going to have your whole anesthesia machine and circuit. You're going to have an oxygenation and ventilation mask. You're going to have your laryngoscope. You're usually going to see a MAC blade like this one. This is a MAC 3 plastic blade. You're going to have your ET tube. So there's some discussion about what size to use. Standard is usually about 7.5 for men, 7 for women. Generally, the bigger your patient is, the bigger the tube you're going to want is. The trade-offs are bigger tube means more flow. If you remember, this is R to the 4th power for flow. But bigger tube, more trauma you're going to cause to the patient. The harder it is to actually thread it through. Different people like to use different size tubes, just like different people like to use different blades. You can use a stylet, which is this little metal piece you see sticking out of the ET tube. This can help you apply some curvature and help you actually get it to where it's supposed to go, which is really nice when you're just starting. You're going to need some tape to tape things in place and tape their eyes shut, and you're going to need your induction and paralytic agents. So, all right, you're ready to intubate. Awesome. But you want to make sure you can ventilate your patient first. When you go to intubate, the patient is not breathing. If you fail, if they have difficult anatomy, if your preceptor fails, you're in big trouble. You want to make sure you can actually ventilate them. So that means, can you put a mask on their face and bag the patient to breathe for them? So the trick to this is try to get the mask flat and flush with your thumb and index finger. And use your other three fingers to pull the patient's face into the mask. You don't want to push down. You want to pull them into the mask. You're going to hear C grip, chin lift, and jaw thrust a lot. Your preceptor can show you what exactly that means. Also, make sure when you're bagging the patient, you turn on that APL or adjustable pressure limiting valve, because if it's not turned on, you're not going to actually be able to deliver any air. You have to give it some resistance. All right, so you really went into intubate already. Great, but do you know the anatomy? Do you know what you're trying to do? So if you're using a Mac blade, a curved blade like this, what you want to do is you go in above the tongue and you want to visualize the epiglottis as shown, and you want to hook it into the vallecula. So you want to approach the epiglottis, hook it into this little space, and then you're using your blade to lift up to help visualize the vocal cords better. If you're working with somebody that happens to use a Miller blade, this is a little more infrequent from my experience. This is a longer straight blade that's actually going to hook underneath the epiglottis and is going to lift everything up in order to visualize the vocal cords. So, all right, so what are you doing in general? So, all right, so you're bagging the patient. So you're going to remove this mask. You're going to get the patient in position, which we'll talk about in a bit. And you're going to open the mouth and insert the blade. So generally, you're going to have the blade in your left hand, and you're going to open the mouth with a scissor grip. So you're going to use your thumb and index finger, and you're going to push your thumb up and index finger down to pry open their teeth. You're going to sweep your blade to the left to get the tongue out of the way. You're going to see that epiglottis, and if you're using the Mac, you're going to get it in the tip of the vallecula. In the Miller, you're going to have it posterior and lift everything up. And when you go to lift up, it's very, very important to lift up and away from you towards the opposite wall. So straight up and away. You don't want to turn your wrist at all, even though it's tempting, because you're going to, boom, break the patient's teeth, and you, the patient, and your preceptor are going to all be very unhappy. And then when you visualize the vocal cords, you can put the ET tube in to about the 20, 21 mark. Depends on the tube and the patient. All right, some tips from my experience. So first and foremost, do what your preceptor does. If they tell you to do something different than what I'm talking about, do that. I've seen a lot of different things. Like some don't want me to have my hand in the patient's mouth at all. Some just kind of like move the head and the chin. Also, they've told me to get my hand out of the way as soon as I'm able to get my blade in. One constant I've seen is they've always had me have the tube in my right hand, the scope in my left hand. Super important thing is positioning. So you're going to hear about the sniffing position. So that is lower cervical flexion with mid-cervical extension. So you are going to put the patient's head back a little bit, try to create this straight line for yourself. I cannot emphasize enough how important this positioning is. What I like to do is I like to pull the patient's head back a little bit when I start, and when I scissor open their mouth, I pull their head back into position. A pillow can be really detrimental for you. It's nice to have them flat on the bed and pull them back. Also, if you're a tall person like me, adjust the height of the bed accordingly. Even if your preceptor is short, adjust the height to make life easier for yourself. Also, you want to keep a level posture while you're doing all of this. You don't want to lean in to try to see. It's actually going to work against you the entire time. I can't emphasize enough how important positioning is for success. Also, this was huge for me, grip. When I started, I had a really tight grip on the blade as I was entering, and I had a really hard time maneuvering around. Then I switched to a looser grip closer to the blade. This has a stubby handle, but I was closer to the blade, and this allowed me to really easily glide past everything, push the tongue out of the way, and see the epiglottis. Once I was in position, I could just easily switch my grip to a stronger one and lift up to see the cords. Another helpful thing is cricoid pressure. Your preceptor or the nurses can help you out with this. If you can't see the cords, sometimes just playing a little bit of cricoid pressure, usually a back up and to the right, is going to help. If you still don't see them, put your hand over their hand, move things around until you're at the right spot, and then tell them to hold that position. Last thing, if you can't see the epiglottis at all, sometimes back out. It could be much more shallow than you expect, especially if you're using a Mac 4 blade. You might be past it, so back out a little bit, and you'll see the flap drop down, and then you know that you're in the right space and you're able to get in the vallecula and lift up. Mach 3 normally can get to where you need to go. I've only had a couple of patients in my experience where I really struggled to get deep enough. So yay, you displaced the tube. All right, party time. But there's some things you need to do really quickly. So first of all, make sure the ET tube is placed at the right depth. So that like 2021 usually. If you're using a stylet, that piece of long metal to help give you some curvature and stiffness, remove it. So lots of times you're going to just put the tip of your ET tube in, and then you're going to remove the stylet and advance. You need to inflate the cuff of the ET tube with your 10 cc syringe. It has that little balloon on it that actually creates the seal. If you don't inflate this, you're not going to get good ventilation. Then you're going to connect your circuit, and you want to see if you're in the right place. The absolute best way to know if you're in the right place is 5 consecutive high end tidal CO2s. So you're going to connect it, you're going to squeeze your bag 5 times really quickly, and you're going to see your end tidal of 30 or 40. If you see an end tidal of 5, or if you see it approaching 0, that means you probably intubated the esophagus. You are still going to get some minor end tidals. Some other things you can look at are chest rise, breath sounds with a stethoscope, and some fogging of your tube. But again, these can be deceiving. It can be tough to hear breath sounds, and you can still see chest rise and fogging if you intubate into the esophagus. Once you've confirmed you're good to turn on your ventilator and tape the tube down and tape the rise shut. Now, extubation. So you would think extubation is easy, right? You just, you deflate your cuff and you pull out the tube and that's that. But timing this is extremely difficult in my opinion. It takes a long time to get a feel for when the patient is ready to breathe on their own. Very important thing to remember is you want to extubate when they're either awake or when they're deep, not in that second stage. That can cause laryngospasm. So some things to do when you're extubating, you want to turn off your anesthetics, you want to reverse with your neoglyco, and you want to let your patient try to start to breathe on their own. Let them build up end tidal CO2. High end tidal CO2 is what tells the brain, hey, it's time to start breathing. If your patient is obstructed, you can do some suction, chin lift, jaw thrust as needed is really helpful, especially after you extubate. As you're extubating, you really want to suction too because there's going to be a lot of secretions. Some signs to note that they are ready: stable vitals, normal ABG in more complex cases. With reversal, is the train of 4 effective? Are they moving at all? Can they lift their head? Do they have a grip? Do you see good tidal volumes? That's something I like to look for. If I see short breaths of just 50 or so, I don't think they're ready. I want to see tidal volumes at greater than 200. Also, if they're starting to gag and cough, you know that they have the reflexes and they're just about ready. So you're probably going to see LMAs or laryngeal mask airways just as much as you're going to see intubations. So you take this device and you insert it right on top of the glottis. So it's basically an oral airway that doesn't have a complete seal. So there's still some aspiration risk. You're not going to be able to ventilate with it as well as you will with an ET tube. So these are a lot simpler to put in. Just do it how your preceptor does it. But I think positioning is key for this. If you just try to shove it in, you're not going to have much success. Really get the patient in proper position, just like you would for an intubation, and make sure you can open up their mouth to insert the device. So in general, there are 2 uses for this. So one, when you don't need an ET tube, if you're not completely paralyzing the patient, maybe it's a simpler case where they can just breathe on their own. An LMA works great. Don't put in an ET tube if you don't have to. The other is an emergency airway. So if you can't intubate, an LMA is pretty good to help oxygenate your patient. So difficult airway algorithm, this is super important. It's not that big, so I encourage you to just go to ASA and look up the algorithm itself. So if you have a difficult airway, that means you have trouble ventilating and or intubating the patient. So some risk factors, your thyromental distance, so you're putting 3 fingers here. If they have distorted anatomy, maybe they have some cancer, maybe there's some radiation or trauma. If they have a really high Mallampati score, if they have a short, thick neck, a lot of your bariatric patients can give you trouble. Lots of facial hair can make it difficult to ventilate. And if they have limited neck range of motion for you to position them correctly, that's going to give you some trouble. So the most important thing is to just be prepared. If you think it's a difficult airway, make sure you have help ready, or a videoscope, an LMA. Make sure you have your backups ready. Oxygenate throughout. If you can ventilate them, amazing. Then you can keep your patient alive. If it seems like you're having trouble, don't repeatedly try to intubate. Call for help. If something isn't working, don't try to do it over and over again. If you anticipate a difficult airway, you can always do an awake intubation. You can use some topical lidocaine to help numb the patient since intubating is very uncomfortable. And then use an LMA as an emergency device if you can't intubate. Use a video bronchoscope so you can visualize better and actually get that tube in. Absolute worst case scenario, hopefully none of us will ever see it in our careers. If you cannot intubate or ventilate, if your patient is dying, you put in an emergency airway. You do the cricothyroidotomy. This is normally done by a surgeon, preferably a trauma surgeon or ENT if you have them available. It is usually not going to be you that does this, and it is extremely rare. I wanted to make a note about time to desaturation. So a normal, young, healthy patient, they can be fine with, 7 minutes without oxygen. If you're intubating in 30 seconds, then great. Or if you're having some trouble, then they'll be fine. If you have an ill, very obese patient, they don't have much reserve. You can see these patients start to desaturate in the 30 seconds it takes you to do a normal intubation. So be mindful of this and be speedy. Also, look at your patient. Are they turning blue? And don't just look at the pulse ox. You can hear it. It changes pitch as they're desatting. So just general flow of what to expect with general OR anesthesia. So one, just prepare. Make sure you see what's coming. Be ready for it in case there's an emergency. Your patient's going to get versed, usually pre-op or right as they enter the OR. They need to sign their consents first. Then go onto the bed. You're going to help hook up all the monitors, your pulse ox, your EKG, your blood pressure, and they're usually going to come with a bag of saline or lactated ringer. Check and make sure your IV is flowing. Make sure all this is okay. Make sure you have antibiotic ready if they need antibiotic. And then start to oxygenate the patient. You want to pre-oxygenate them so that when they do have that time, when you're intubating and they're not able to breathe on their own, they have a nice oxygen reserve. Once all that's ready, you give your induction agent like propofol. You give your neuromuscular blocking agent. So lots of times you'll see succinylcholine given at first. Folks could just use rocuronium, but you have to wait a moment for that to kick in. You could also use a combination of the two, depending on the case. And then you do your intubation successfully, I hope, and you turn on your gas and your ventilator. You want to give your pain medications. Lots of times you'll give some fentanyl up front. Lots of folks give this even before they put in the propofol. You can give things like IV Tylenol throughout the case. Give your post-op nausea vomiting meds sometime during the case, like your Zofran, Reglan, Decadron. And then as the surgery is happening, you're monitoring everything. You want to know what's going on. Is there something going wrong with the surgery? Look at your patient's vitals. Make sure they're not getting hypotensive. Then when everything is done, if appropriate, you can perform a pain management block. Then you reverse your patient. Then you turn off that gas and you try to blow it off. Turn up the flow rate really high. You might only have a flow rate of gas at about 2, and this really helps to conserve your gas. But as you're trying to blow it off, crank it up to 10. Get that out of their system. And then, like we talked about with extubation, wait till they're ready and get that tube out, and then hand them off to the PACU, and you can do a little dance in private because congratulations, you didn't kill your patient. Some other things with anesthesia, we have our TAP block, transabdominal plane block, that you'll likely see, especially after any abdominal, like GI surgeries. So basically, you're injecting local anesthetic in the plane between the internal oblique and transverse abdominis. It's a lot harder than it looks to do. I encourage you to try it out. Spinal and epidural anesthesia, these are examples of regional anesthesia. So again, you're using your local anesthetics, like your bupivacaine or ropivacaine for these. Your epidurals, you're going to see a lot during labor, and spinals you're going to see during C-sections, or they could be used for a lot of other surgeries too, like hips and knees. They'll often get spinals alone or in addition to other anesthesia. A common question they're going to ask you is what layers are pierced during a spinal and epidural. So you go through your skin, fat, then your ligaments are your supraspinous, intraspinous, and then ligamentum flavum. And you're going to go into the epidural space. If you're doing a spinal, you're going through the dura into the subarachnoid space. Some differences between them based off of that depth is your spinal, you're going to get some CSF return. That's how you know you're in the right place. You don't need to use as much, and it's a really quick, strong sensory and motor block. Just a one-time bolus. Epidural is going to be a little weaker, and it's continuous. You're giving this to your patient as they're going through labor. This could last hours. You also don't want a motor block. You know you're in the right place because it's a potential space. You'll see them use saline or air to see if they're able to push it and know they're in the right spot. They're also going to do test doses to make sure they're not injecting the anesthetic into circulation. They may ask the patient if they're experiencing that metallic taste or tinnitus. There are a lot of other examples of regional anesthesia you'll see. Just want to briefly mention cardiac anesthesia. I mostly think coronary artery bypass graft or CABG. There's other surgeries where cardiac anesthesia applies. Just know that if you're taking part in this, there's a lot of preparation. You're going to be doing a central line, an A line, a TEE, and then there are a lot of medications to set up and be ready for these cases. They're extremely complicated. You also want to keep in mind that your anesthetic strategy should be as cardioprotective as possible. I had a preceptor that just used fentanyl as the main anesthetic because that is cardioprotective versus your gases. You're also going to have a perfusionist present. So when they actually go on bypass, you're turning your ventilator off. Their perfusion is circulating everything through, giving a cardioplegic solution and gases and getting ABGs, and they're controlling the patient. You're not doing anything. You also might hear the surgeon ask you to turn the lungs off or down. That means turn off your ventilator so they can do something without damaging the lungs for a moment, and then you'll turn it back on. You also might encounter one lung anesthesia if they're operating on one of the lungs, like a thoracotomy. You're going to use a double lumen ET tube. So this is just a special device we are able to only inflate one lung. So you're going to put the patient on the side of the good lung while they operate on the quote-unquote bad lung. This is also nice because the ventilated lung being down is going to get more blood flow due to gravity. It's going to lower your VQ ratio. Last but not least, why is anesthesia great? You get to do acute problem solving and critical care. You see a problem, you figure it out, you solve it right then and there. So it's like internal medicine where you need to have this vast knowledge of physiology, but you take hands-on action. I mean, you're the one who's figuring out what drugs they need and giving them to the patient right away. You're doing procedures. It's awesome. You get to work with a lot of interesting technology, and this is going to change a lot as we progress through our training. There's also an art to it. There's not a perfect way to handle every case. There's a lot of differing opinions. There's a lot of research out there. There's a lot of ways to solve different problems, and one of them isn't necessarily better than the other. There's a lot of trade-offs. Also, there's no homework. When you go home, you're done. And you don't have to write these gigantic notes like you would for internal medicine. Money's pretty good too. And the lifestyle, it's not bad, especially compared to a lot of the surgical specialties. Also, just ask your preceptor why they like it. I think every anesthesiologist I've met has loved their job, has been really happy, and recommended it. And I can't say that about a lot of other specialties. All right, well, that's it. I hope this was helpful, and you can do great on your anesthesia rotation.